In the name of Almighty God, I am Mahsa Sankosha, and today I want to talk about pacemaker electrode with annotations. A pacemaker is a small battery-operated medical device implanted under the skin to help regulate an abnormal or slow heartbeat. It consists of a pulse generator which contains the battery and circuitry, and one or more leads wires that are attached to the heart. The pacemaker monitors the heart's natural rhythm and sends electrical impulses to the heart muscle to make it contract, ensuring it beats at a normal and regular rate. And how it works? The first one is sensing. The leads have electrodes that detect the heart's natural electrical activity. The next step is pacing. If the pacemaker senses that the heart is beating too slowly or irregularly, it sends a small electrical pulse through the leads to stimulate a heartbeat. The next step is on demand. Most modern pacemakers work on demand, meaning they only pace when necessary. They can adjust their rate in response to physical activity, speeding up when you are active and slowing down when you are resting. The next step is implantation. The device is typically implanted in the chest just under the collarbone with the leads guided through a vine to the heart. And what are the types of pacemakers? The first type is single lead pacemaker. Uses one lead usually in the right ventricle. The next type is dual lead pacemaker. Uses two leads, one in the right atrium and one in the right ventricle. The next type is a biventricular pacemaker or CRT, uses three leads and helps the heart's two lower chambers ventricles beat in a more coordinated way. The next type is wireless pacemaker, a newer type that is placed directly inside the heart and doesn't require a wire. And why a pacemaker is needed? The first one and the first reason is a slow heart rate. The most common reason is a condition called bradycardia, where the heart beats too slow. A pacemaker electrode is a flexible insulated wire with a tip that conducts electrical impulses from the pacemaker's pulse generator to the heart muscle. It is one component of a pacemaker system which also includes the generator, and its function is to send electrical signals to help regulate the heart's rhythm. These electrodes are threaded through a vine to reach the heart, where the tips are attached to the heart wall to deliver a stimulation. And how it works? The first step is connection. One end of the electrode lead connects to the implanted pacemaker's pulse generator, the battery and circuitry, and the other end, the electrode is attached to the heart valve. And the next step is delivery. The electrode delivers electrical impulses from the generator to the heart muscle to regulate its contraction. The next one is placement. For a standard system, the leads are threaded through a central vine until their tips are in the correct heart chamber. The next one is attachment. The electrode tips often has a small screw or helix that secures it to the heart tissue. And what are the system types? The first type is single chamber, uses one lead either in the atrium or ventricle. The next type is dual chamber, uses two leads, one in the atrium and one in the ventricle. And the next type is biventricular, uses an additional lead on the left ventricle, often used for cardiac resynchronization therapy or CRT. A pacemaker, also known as an artificial cardiac pacemaker, is an implanted medical device that generates electrical pulses delivered by electrodes to one or more of chambers of the heart. Each pulse causes the targeted chambers to contract and pump blood, thus regulating the function of the electrical conduction system of the heart. The primary purpose of a pacemaker is to maintain an uneven heart rate, either because the heart's natural cardiac pacemaker provides an inadequate or irregular heartbeat, or because there is a block in the heart's electrical conduction system. Modern pacemakers are externally programmable and allow to cardiologists to select the optimal pacing modes for individual patients. Most pacemakers are on demand, in which the stimulation of the heart is based on the dynamic demand of the circulatory system. Others send out a fixed rate of impulses. A specific type of pacemaker, called an implantable cardioverter defibrillator, combines a pacemaker and defibrillator functions in a single implantable device. Others, called biventricular pacemakers, have multiple electrodes stimulating different positions within the ventricles, the lower heart chambers, to improve their synchronization. And what are the methods of cardiac pacing? Percussive pacing. Percussive pacing, also known as transthoracic mechanical pacing, is the use of the closed fist, usually on the left lower edge of the sternum, over the right ventricle in the vena cava, striking from the distance of 20 to 30 centimeters to induce a ventricular beat. And the British Journal, this is come from the British Journal of Anesthesia, suggests this must be done to raise the ventricular pressure to 10 to 15 millimeter pressure to induce electrical activity. This is an old procedure used only as a life-saving means until an electrical pacemaker is brought to the patient. And what about the transcutaneous pacing? Transcutaneous pacing, also called external pacing, is recommended for the initial stabilization of hemodynamically significant bradycardias of all types. The procedure is performed by placing two pacing pads on the patient's chest, either in the anterior lateral position or the anterior posterior position. The rescuer selects the pacing rate and gradually increases the pacing current measured in milliampere until electrical capture, which means characterized by a wide QRS complex with a tall, broad T wave on the ECG, is achieved with a corresponding pulse pacing artifact on the ECG, and severe muscle twitching may make this determination difficult. External pacing should not be relied upon for an extended period of time. It is an emergency procedure that acts as a bridge until transvenous pacing or other therapies can be applied. The next is epicardial pacing. Temporary epicardial pacing is used during open heart surgery should the surgical procedure create atrioventricular block. The electrodes are placed in contact with the outer wall of the ventricle or epicardium to maintain a satisfactory cardiac output until a temporary transvenous electrode has been inserted. Permanent epicardial pacing leads can be implanted surgically and tunneled to the pulse generator packet. These leads are either passively touching the heart and swing in place, or have a screw mechanism to actively fix to the heart. And what about the transvenous pacing temporary? Transvenous pacing, when used for temporary pacing, is an alternative to transcutaneous pacing. A pacemaker wire is placed into the vein under sterile conditions and then passed into either the right atrium or right ventricle. The pacing wire is then connected to an external pacemaker outside the body. Transvenous pacing is often used as a bridge to permanent pacemaker placement. It can be kept in place until a permanent pacemaker is implanted or until there is no longer a need for a pacemaker, and then it is removed. The right atrial and right ventricular leads are visualized under X-ray during a pacemaker implant procedure. The atrial lead is the curved one making a U shape in the upper left part of this simulation. And what about the permanent transvenous pacing? Permanent pacing with an implanted pacemaker involves transvenous placement of one or more pacing electrodes within a chamber or chambers of the heart while the pacemaker is implanted under the skin below the clavicle. The procedure is performed by incision of a suitable vein into which the electrode lead is inserted and passed along the vein through the valve of the heart until positioned in the chamber. The procedure is facilitated by fluoroscopy, which enables the physician to view the passage of the electrode lead. After satisfactory lodgement of the electrode is confirmed, the opposite end of the electrode lead is connected to the pacemaker generator. There are three basic types of permanent pacemaker classified according to the number of the chambers involved and their basic operating mechanism. The first type is single chamber pacemaker. In this type, only one pacing lead is placed into the chamber of the heart, either the atrium or the ventricle. The next type is dual chamber pacemaker. Here wires are placed in two chambers of the heart. One lead paces the atrium and one paces the ventricle. This type more closely resembles the natural pacing of the heart by assisting the heart in coordinating the function between the atria and ventricles. The next type is a biventricular pacemaker. This pacemaker has three wires placed in three chambers of the heart, one in the atrium and two in either ventricle. It is more complicated to implant. And the next type is rate responsive pacemaker. This pacemaker has sensors that detect changes in the patient's physical activity and automatically adjust the pacing rate to fulfill the body's metabolic needs. The pacemaker generator is a hermetically sealed device containing a power source, usually a lithium battery, a sensing amplifier which processes the electrical manifestation of naturally occurring heartbeats as sensed by the heart electrodes. The computer logic for the pacemaker and the output circuitry which delivers the pacing impulse to the electrodes. Most commonly, the generator is placed below the subcutaneous fat of the chest wall, above the muscles and the bones of the chest. However, the placement may vary on a case-by-case basis. The outer casing the outer casing of pacemaker is so designed that it will rarely be rejected by the body's immune system. It is usually made of titanium, which is inert in the body. And what about the leadless pacing? Leadless pacemakers are devices that are as small as capsules and are small enough to allow the generator to be placed within the heart, therefore avoiding the need for pacing leads. As pacemaker leads can fail over time, a pacing system that avoids these components offer theoretical advantages. Leadless pacemakers can be implanted into the heart using steel steerable catheters fed into the femoral vein via an incision in the groin. And the basic function pacing modes. Modern pacemakers usually have multiple functions. The most basic form monitors the heart's native electrical rhythm. When the pacemaker wire or lead doesn't detect heart electrical activity in the chamber, atrium, or ventricle within a normal beat-to-beat time period, most commonly 1 second, it will stimulate either the atrium or the ventricle with a short low voltage pulse. If it does sense electrical activity, it will hold off stimulating. This sensing and stimulating activity continues on a beat by beat basis and is called demand pacing. In the case of a dual chamber device, when the upper chambers have a spontaneous or stimulated activation, the device starts a countdown to ensure that in an acceptable and programmable interval there is an activation of the ventricle. Otherwise, again, an impulse will be delivered. From this, the basic ventricular on-demand pacing mode is VVI, or with automatic rate adjustment for exercise, VVRI. Um, this mode is suitable when no synchronization with the atrial beats is required. As an atrial fibrillation, the equivalent atrial pacing mode is AAI or RIR, which is the more mode of choice when atrioventricular conduction is intact, but the sinoatrial node of the natural pacemaker is unreliable. Sinus node disease, or SND, or sick sinus syndrome, where the problem is atrioventricular block, or AVB. The pacemaker is required to detect sense the atrial beat, and after a normal delay zero point 0.1 to zero point 0.2 seconds trigger a ventricular beat unless it has already happened. This is VDD mode and can be achieved with a single pacing lead with electrodes in the right atrium to sense and ventricle to sense and pace. These modes, RRIR and VDD, are unusual in the US but mm, widely used in Latin America and Europe. The DDDR mode is most commonly used as it covers all the options, though the pacemakers require separate atrial and ventricular leads and are more complex, requiring careful programming of their functions for optimal results. Automatic pacemakers are designed to be overridden by their heart's natural rate at any moment that it gets back to a non-pathologic normal sinus rhythm and can reinitiate, influencing the electric activity in the heart when the pathologic event happens again. A ventricular demand pacemaker produces a narrow vertical uh, spikes on the ECG just before a wide QRS. The spike of an atrial demand pacemaker appears just before the P wave. Comparably, a triggered pacemaker is activated immediately after an electrical activity is commenced in the heart tissue by itself. A ventricular triggered pacemaker produces the impulse just after a pulse is created in the ventricular tissue and it appears as a simultaneous spike with QRS. An atrial triggered pacemaker is the mode in which an impulse is produced immediately after an electrical event in the atrium. It appears as a discharge following the P wave but prior to the QRS, which is commonly widened. And about threshold, the heart is composed of an excitable tissue, and an electrical pulse of a certain voltage is needed to capture the myocardium to make the heart function. The minimum voltage to achieve this is called the threshold. As this is a probabilistic property, the actual voltage used is higher than the threshold, usually by a 50 to 100% margin. Additionally, the electric pulse has a time component, and the proper description of the threshold is a voltage and pulse width. And all electrical circuits require a complete connection between the cathode and the anode. For some pacing leads, both connections to the heart are provided in a single lead, bipolar, and some only provide a single connection, unipolar. In unipolar, the second connection is internally from the heart to the generator through the body, blood tissue, and etc. Also important is the impedance. The lower the impedance, the more current is needed to achieve the threshold voltage and lowers the battery life. The impedance is affected by the integrity of the pacing lead and the electric tissue interface of the lead with the heart. And the next is sensing and sensitivity. An important aspect of pacemaker function is sensing the intrinsic heart activity. This is called sensing. Larger sense voltage are desired, and it's expected that the ventricle produces a large voltage than the atria. The minimum voltage to sense an event is called the sensitivity. The higher the sensitivity, the less that is sensed, and the vice versa. Too low of a sensitivity can cause troubles with sensing P waves, T waves, and noise. Sensing these things is called oversensing. A sensitivity too high may result in missed sensing of P waves in the atria and QRS in the ventricles and is called undersensing. And what about the biventricular pacing? Cardiac resynchronization therapy or CRT is used for people with heart failure in whom the left and right ventricles don't contract simultaneously. Ventricular dyssynchrony, which happens in approximately 25 to 50% of heart failure patients. To achieve CRT, a biventricular pacemaker or BVP is used, which can pace both the septal and lateral walls of the left ventricles. By pacing both sides of the left ventricles, the pacemaker can resynchronize the ventricular contractions. CRT devices have at least two leads, one passing through the vena cava and the right atrium into the right ventricle to stimulate the septum, and another passing through the vena cava and the right atrium and inserted through the coronary sinus to pace the epicardial wall of the left ventricle. Often for patients in normal sinus rhythm, there is also a lead in the right atrium to facilitate synchrony with the atrial contractions. Thus, the timing between the atrial and ventricular contractions, as well as between the septal and lateral walls of the left ventricles, can be adjusted to achieve optimal cardiac function. CRT devices have been shown to reduce mortality and improve quality of life in patients with heart failure symptoms. A LV ejection fraction less than or equal to 35% and QRS duration on EKG of 120 milliseconds or greater. Biventricular pacing alone is referred to as CRTP for pacing for selected patients at risk of arrhythmias. CRT can be combined with an implanted cardioverter defibrillator or ICD. Such devices known as CRT-D for defibrillation also provide effective protection against life-threatening arterial arrhythmias. And what about the conduction system pacing? Conventional placement of ventricular leads in or around the tip or apex of the right ventricle or RV apical pacing can have negative effects on the heart function. It has been associated with increased risk of atrial fibrillation, heart failure, weakening of the heart muscle, and potentially shorter life expectancy. This bundle pacing or his pacing HBP and left bundle branch area pacing or LBBAP leads to a more natural or perfectly natural ventricular activation and has generated a strong research and clinical interest. By stimulating the his Purkinje fiber network directly with a special lead and placement technique, HBP causes a synchronized and therefore more effective ventricular activation and avoid long-term heart muscle disease. HBP in some cases can also correct bundle branch block patterns. And what about the advancement in function? A major step forward in pacemaker function has been to attempt to mimic nature by utilizing various inputs to produce a rate-responsive pacemaker using parameters such as the QT interval, POT or PCOT, dissolved oxygen or carbon dioxide levels. In the arterial venous system, when physical activity as determined by an accelerator, body temperature, ATP levels, adrenaline, and etc. Instead of producing a static, predetermined heart rate or intermittent control such a pacemaker, a dynamic pacemaker could compensate for both actual respiratory loading and potentially anticipated respiratory loading. The first dynamic pacemaker was invented by Anthony Rickards of the National Heart Hospital, London, UK in 1982. Dynamic pacemaking technology could also be applied to future artificial hearts. Advances in transitional tissue welding would support these and other artificial organ joint tissue replacement efforts. Stem cells may be of interest in transitional tissue welding. Many advancements have been made to improve the control of the pacemaker once implanted. Many of these have been made possible by the transition to microprocessor-controlled pacemakers. Pacemakers that control not only the ventricles but the atria as well have become common. Pacemakers that control both the atria and ventricles are called dual-chamber pacemakers, although these dual-chamber models are usually more expensive. Timing the contractions of the atria to proceed that of the ventricles improves the pumping efficiency of the heart and can be useful in the congestive heart failure. Rate-responsive pacing allows the device to sense the physical activity of the patient and respond appropriately by increasing or decreasing the base pacing rate via rate-response algorithms. The DAVD trials have shown that unnecessary pacing of the right ventricle can exacerbate heart failure and increases the incidence of atrial fibrillation. The newer, the newer dual chamber devices can keep the amount of right ventricle pacing to a minimum and thus prevent a worsening of the heart disease. And what about the considerations? Insertion. A pacemaker may be implanted whilst a person is awake using a local anesthesia to numb the skin with or without sedation or sleep using a general anesthetic. Antibiotic is usually given to reduce the risk of infection. Pacemakers are generally implanted in front of the chest, in the region of the left or right shoulder. The skin is prepared by clipping or shaving any hair over the implant site before cleaning the skin with a disinfectant. And here you can see the capsule software simulation and the geometry that have been designed for pacemaker, and the material is hard tissue. And you can see that we have selected the electric conductivity and relative permittivity. And also I have used electric currents as EC physical module, uh, and defining current conservation, electric insulation, initial value, ground, and electric potential. And after that, you can see the three-dimensional plot groups. That is here that you can see electrical potential and current density. This is electrical field. Electrical field norm based on volt per meter, and electrical potential. Thank you so much for watching my video until the end. And also you can download this pacemaker electrode with annotations from my github.com/mahsa